we're going to look here at the Norwich Image Interpretation Learning Outcomes of the hand X-ray. Assessing the X-rays in a systematic approach, we can avoid bias, approaching each X-ray in the same way, understanding the importance of radiographic technique and positioning, and how that affects the image, describing basic anatomy, understanding common mechanisms of injury and which injuries can result from these, looking at subtle injuries, the ones that are least commonly occurring but most commonly missed, describing common dislocations and their associated fractures, how they're dislocated, which direction they're going, how are we describing these dislocations, and why have they happened, or how have they happened, understanding common eponyms, types of fractures that we can see, Salter-Harris, Torus, etc. Knowing common avulsion sites and ligamental injuries, which projections can we use to best demonstrate these, and overviewing of the Salter-Harris classification, and at the end just touching briefly on common lytic lesions. I'm going to show you some common positional errors. This is a cartoon of a finger, the distal end of a finger. We got the nail bed. You can see it's quite fair to say that the nail bed is equidistant to the skin margin. This is a good position for a DP. And technique error here, a bit of rotation from the nail bed, and the finger looks a little bit rotated to the left here. This is going to significantly impact the X-ray. And also looking in a horizontal view, this is a good position of a finger pointing directly forward, but we do see sometimes positional errors where the finger is pointing down or up, and these can cause errors. Positional errors can cause problems for interpreting the image. This would be the phalanges in a good position, clearly seen through the joint space. With these kinds of positional errors, you're going to have a DP that looks a bit like this, and there's some overlap between the phalangeal bones. We can't clearly see through these joint spaces because the bones are overlapping each other in these planes, because this is the direction of our primary beam. Yeah, we're not going to see through the joint space at all, and ultimately we're unable to accurately assess the cortex of each individual bone. And earlier I was talking about rotational errors of the finger. Expect to see something a little bit like this in the DP, where there's some curvature of the phalanx bones. One side's going to be quite flat and the other side's going to be quite significantly turned. It's more a oblique view, as you can imagine. This is not the view that we're trying to go for. Here's an example of a hand X-ray. Basic overview of the anatomy. We've got the distal radius, the distal ulna, the carpal bones. More specifically, we'll cover in the wrist module, metacarpals, and the phalanges. In the second, third, fourth, and fifth, we've got the distal, middle, and proximal phalanx. And in the thumb, we only have two phalanges, the proximal and distal phalange. There's a good demonstration of the joint spaces in between the phalanges. There's definite separation between those bones, and we can clearly assess the cortex and joint spaces. The hand in its entirety is in a good AP position, the hands flat, and this allows us to demonstrate the anatomy in its correct way. Here's an example of a injury, an avulsion fracture at insertion of a collateral ligament. This is the second digit of the hand, and there's a small avulsed fragment of bone there from the collateral ligament. It's demonstrated in the DP view of the finger. It's not so clearly seen in the lateral. There's a break in the cortex and we can clearly see the avulsed fragment. Commenting on the positional technique of this X-ray, you can see through the joint space there's no overlap between the phalanges, both in the DP and lateral. You can clearly see through the joint space and we can assess the cortex. The subtle fragment arises from the medial collateral ligament, so we're going to need to think about what kind of injury this may have been caused by. A few to think of are catching the finger in bag handles, doors, also catching objects, falling onto the hands and fingers, and laterally moving the finger bones side to side. You can also see a significant amount of soft tissue swelling here on the medial side. Here's another finger X-ray, and we're looking specifically at this hyperextension injury, and there's an avulsion fracture at the insertion of the volar plate or the joint capsule of the finger. So the injury is at the proximal interphalangeal joint, not the distal interphalangeal joint. And quite similarly with the last X-ray that we looked at, it's not so easily picked up from the corresponding view. So in the lateral we can clearly see this volar plate fracture, avulsion fracture. In the DP finger it's not so clear. Here's the proximal interphalangeal joint. Not much noticeable here, not much injury to see at all. But in the lateral view we can clearly see the avulsed fragment. So that just personifies the importance of the two views, specifically in the finger X-ray series. And the hyperextension injury can be commonly seen with catching a ball, similarly as before, and also falling on fingers and hyperextending the interphalangeal joints. And this injury is at the palmar aspect of the finger, so it's a hyperextension. Here's another avulsion fracture of a volar plate. This is at the extensor tendon, and this is at the distal interphalangeal joint. Once again, not very well demonstrated in the DP view, but in the lateral view, very clearly seeing the avulsed fragment. And just by looking at the soft tissue of the finger, we're looking at soft tissue, connective tissue injury, so there's going to be some disruption in the function of the finger. So we're going to see flexion and extension deformities. Here's another deformity of the flexion, and this one is a mallet deformity at the distal interphalangeal joint. Not sure why the pen is there, but we cannot see a associated bone fragment, but we can definitely see a deformity, and this is due to the tendon rupturing. We can just about see in this picture a volar plate avulsion to the index finger, but this is like a oblique hand, and we can't clearly see the extent of the avulsion fracture in this oblique view. We can't fully appreciate the injury from this view. And that just reiterates the importance of the lateral view for the finger series, picking up these small avulsion fractures, clinically important fractures. Clinically important because they can be very affecting the lifestyle of the patient. Not having a lateral view, we are unable to fully demonstrate the extent of the injury, and more so the extent of the displacement of the fractures. Looking at dislocations of the finger, this is a dorsal dislocation of the proximal interphalangeal joint. This also has a small avulsed fragment here as well. How we describe this dislocation is the direction of the bone most distal to the joint affected in relation to the bone that is more proximal to the joint affected. So in this case, the middle phalanx is moving dorsally away from the proximal interphalangeal joint, and this is why we call it a dorsal dislocation. And I believe due to the nature of this injury, can pick up some clues from the DP view of how the middle phalanx has migrated across in that plane and is causing some deformity in the direction of the phalanx. Some of the clues before you actually take some images is the soft tissue deformity. Looking at this lateral here, there's a bulge with associated soft tissue swelling. The patient probably had a lot of difficulty getting into this position. We can see some kind of artifact here, maybe trying to support the distal part of the finger, and able to get us a half decent lateral view. Initially, at the time of first imaging, we can try and pick up on these small avulsed fractures and little fragments that we can see. Once the dislocation has been relocated, we can further assess for any avulsed fragments once we can obtain a true lateral view of the finger. But moving on to fractures of the metacarpal bones now. Commonly seen fourth and fifth metacarpal fractures because they are usually displaced fractures and rarely missed. Common injuries, punching walls, and they involve fractures to the head, neck and base of metacarpals. You can see this is a fracture of the distal shaft of the fifth metacarpal. There is a break in the cortex and there's a displacement of the bone. More easily missed fractures of the metacarpals are at the base. Very similar mechanism of injury. There's a fifth metacarpal fracture here at the base. Once again we can see a break in the cortex, but it's not as obvious and not as clear as the previous film we looked at, but there is still a break in the cortex and slight bit of displacement. These type of injuries can be commonly associated with dislocations of the fourth and fifth metacarpal. There's a fractured fourth metacarpal here, and there's a dislocation of the fifth carpal metacarpal joint. In general, the projections used for this hand X-ray, we have here the DP and the oblique. These are usually seen sufficient to demonstrate these kinds of injuries. However, in practice, it's very common to also obtain a lateral view of the hand for these kinds of injuries of the metacarpals to see the displacement of the bones for any kind of therapy that the patient will receive in ED or fracture clinic follow-up, and can also be for surgery. Just a comparison of these two films, we can see the joint space is reduced at the carpometacarpal joint in comparison to the normal joint spaces here. But in this scenario of a fracture dislocation of the fourth and fifth metacarpals, there's also a fractured hamate fragment. So this summarises the importance of approaching each film in a systematic way, so that these kinds of grotesque injuries, and they're quite obvious on the films, can sometimes stray away your eyes into more subtle injuries, and which have just as much clinical importance. So moving on to the thumb, we can see this is a eponym of called a Bennett's fracture dislocation. There's an oblique fracture through the base of the first metacarpal, and this is a intra-articular fracture of the first metacarpal, usually with dorsal subluxation, and we call this the Bennett's fracture dislocation. Similar to the Bennett's is the Rolando's fracture dislocation of the first metacarpal. This is a more comminuted fracture, and this is a very unstable fracture. You can see it's very comminuted. I would imagine the common kind of injury is catching the thumb with a significant force to dislocate the first metacarpal, and also cause a significant comminuted fracture of the proximal fragment. We'll look at some pediatric films now. This is a Salter-Harris type 2 fracture, and Salter-Harris fractures involve the fascial growth plate and the adjacent metaphysis and or the epiphysis, and a fracture in this area will usually cause a fracture to the weakest point, which is the cartilaginous growth plate, and it would usually spare the stronger joint capsule and its associated ligaments and tendons. So depending on the involvement of the metaphysis and the epiphysis adjacent to the injury, we classify these injuries in the Salter-Harris classification scale. This one, for example, is the Salter-Harris type 2, and it's a fracture extending through the fascial growth plate and the adjacent metaphysis. But the type 1 is a similar injury but does not extend into the metaphysis or epiphysis, has no displacement, and is confined to the fascial growth plate. And here is a good, nice cartoon describing and explaining, visualizing the different types of Salter-Harris fractures, type 1 and type 2, which we've just covered. We also have the type 3, 4 and 5. The type 3 where we have the fracture through the growth plate and the adjacent epiphysis. And this is an intra-articular fracture, and usually involves the ligamentous insertion of the bone. The type 4 involves the epiphysis, fascial growth plate and the metaphysis. And lastly the type 5, which is more of a compression fracture, and these are very subtle and very easy to miss. An observation between the relationship of these types of injuries and the severity can be classified as 1 and 2 more commonly seen, and becoming least common between the type 3, 4 and 5. However, the severity of the injury does increase as well. And if we are talking pediatric imaging, we're talking also about any buccal fractures, or what commonly referred to as torus fractures, buckling and bulging of the cortex, lastly, we're going to touch on the lytic lesions of the phalanx. Here's an encrodoma with a pathological fracture extending through the proximal phalanx. It is usually asymptomatic and usually a incidental finding, but they can fracture. This is a good example of a pathological fracture. And what they can demonstrate is what we call scalloping within the bone with the lobulated appearances. When we see multiple encrodomas, there's a disease called Ollier's disease. This is where there's multiple encrodomas. So that was just a short overview of the hand, fingers, and some lytic lesions, pediatric anatomy of the hands and fingers. Most of this content was produced by the Norwich Image Interpretation Course. Thank you very much for them. It's all free on their website. I was also using some Google images to show some basic anatomy. This was just a simple overview, and in another video I'll be going through some more advanced image interpretation of the hand and fingers and put into practice what we've been discussing in this video.